Welcome to the deep dive. Today, we're tackling a disease that feels like it should be in the past, but, well, it's making headlines again. Measles, or rubeola, as it's also known.
Yeah, it's definitely a topic that shows how quickly things can resurface if immunity drops. We've got a good stack of sources here, medical info, public health reports, some history too.
Right. So, our mission for this deep dive, looking at these sources, is to really get what measles is, understand just how incredibly contagious it is, look at its history before and after the vaccine, and figure out why we're seeing it pop up more now.
And crucially, how we protect ourselves and everyone else.
Exactly. So, let's start with the basics. What is measles, fundamentally?
Okay, so it's caused by a virus, obviously, and the standout feature. It's one of the most contagious diseases we know, period.
How contagious are we talking?
Your sources mention this striking number.
Hmm.
In a household setting, if you have susceptible people who aren't immune, there's at least a 90% chance it'll spread to them.
90%. Wow. It's almost a guarantee if you're not protected and living with someone who has it.
It really is incredibly efficient at spreading.
Okay, so what does it look like? The classic signs.
Well, it usually starts feeling like a really bad cold, but with a high fever, often over 104 Fahrenheit, 40 Celsius. Then you get what they call the classic triad,
Yeah.
a cough, a runny nose, that's the coriasis a bit,
Yeah.
and conjunctivitis, so red, watery eyes.
The three C's.
Exactly. And then a few days into that, you might see these unique little spots inside the mouth. Then the main body rash appears.
And if you get through it.
If you recover from the actual measles infection, your body develops lifelong immunity. It won't forget that virus.
Lifelong immunity is good, but yeah, the illness itself sounds pretty rough. Let's step back in time. What was it like before the vaccine existed?
Pre-1963 in the U.S., measles was just everywhere. The estimates are pretty staggering. Your sources say 3 to 4 million cases every single year.
3 to 4 million a year, so basically everyone got it.
Pretty much. It was considered a standard childhood illness, something you just went through.
Then 1963 happened, the game changer.
Right. The effective measles vaccine arrived, and the impact was almost immediate.
How immediate?
Well, with vaccination programs rolling out, the number of reported cases in the U.S. just plummeted. We're talking more than a 99% decrease. It went from being universal to relatively rare.
Incredible. But it didn't vanish completely, did it? There was that spike later on.
That's right. In the late 80s, early 90s, 1989 to 1991 specifically, there was a significant resurgence.
Who did that affect mainly?
Mostly unvaccinated preschool-age kids. It resulted in about 55,000 cases and, sadly, 130 deaths.
And that led to a change in policy.
It did. That outbreak was a major factor in the recommendation for a second dose of the measles vaccine to really boost immunity and catch those who didn't respond fully to the first dose.
So that second dose helped solidify things.
Yeah, it was a key step towards what public health officials achieved by the year 2000, the effective elimination of endemic measles transmission in the U.S.
Elimination meaning it wasn't constantly circulating on its own anymore.
Exactly. Cases after that were almost always traceable back to someone bringing it in from another country where it was still common. It wasn't self-sustaining here.
Okay, so if it was eliminated here over 20 years ago, why are we doing this deep dive now? Why the comeback?
Well, that elimination status was always fragile,
Mm.
It depended entirely on keeping vaccination rates really high. But after around 2007, the numbers started ticking up again.
And the source?
Mm.
Still importations.
Mostly, yes. Your sources are clear. Most U.S. cases are linked one way or another to international travel. But the key point is, the virus could only spread once it arrived because it found pockets of people who weren't vaccinated, communities with lower immunity.
Let's talk recent numbers. What do the sources say?
Well, 2019 was a good year, relatively speaking. 1,274 cases in the U.S., the highest number since 1992. Again, linked to travelers and unvaccinated groups.
And more recent?
For 2024, up to the reporting date, there were 285 U.S. patients.
Yeah.
And here's a key detail, the age breakdown. Over 70% were under 20. 42% under 5, another 31% aged 5 to 19.
So mostly kids and teens.
Primarily, yeah.
Oh.
And we've even seen specific outbreaks in 2025 cropping up in U.S. counties known to have lower vaccination coverage.
And this isn't just a U.S. issue, right? This is global.
Oh, absolutely. While it's eliminated in some places, measles is still very common in many parts of the world. And globally, the trend has actually been going the wrong way recently.
How so?
Your sources point to the COVID-19 pandemic having a major negative impact. Worldwide measles vaccination coverage dropped during that time.
And the consequences.
Pretty stark. Measles-related deaths globally jumped 43% in 2022 compared to 2021. That year saw about 9 million cases and a devastating 136,000 deaths worldwide, mostly children.
136,000 deaths in 1 year.
Yeah. And 2023 wasn't much better, around 107,500 deaths globally. Looking at Europe specifically in 2024, they've seen a huge surge, over 127,000 cases reported, double the previous year, the highest since 1997. It just shows how fast it comes back when immunity falls.
That global context is really sobering. It brings up a crucial point. Even if a place has high vaccination rates overall, why can outbreaks still happen?
It boils down to just how incredibly infectious measles is. Your sources explain that even if, say, 95% of a population is vaccinated, which sounds great, that remaining 5% who are susceptible, if they're clustered together, maybe in a specific community or school.
That's enough fuel for the fire.
That's enough. It's enough to sustain periodic outbreaks. Measles is brilliant at finding those gaps in the herd immunity wall.
And unfortunately, those gaps seem to be widening in some places.
That's the concern. In the U.S., MMR vaccine coverage among kindergarteners has dipped below that 95% target since 2020, and it's not uniform. Some communities have much lower rates.
And the risk for those kids?
The sources state it clearly. Unvaccinated young children have a more than 60-fold increased risk of getting measles if they're exposed, 60 times higher.
We have to touch on why some of these rates are falling. It's complex.
It is. And your sources neutrally report on this, the impact of scientifically unsubstantiated claims linking the measles vaccine to autism. Despite overwhelming evidence showing no link, these claims have unfortunately led some parents to delay or refuse vaccination.
And that directly impacts community immunity.
Directly. Lower vaccine uptake creates those vulnerable pockets where measles can and does return.
There's a really tragic example of this playing out from Samoa in 2019.
Yeah, the Samoa situation is just heartbreaking and a stark lesson. They declared a state of emergency that year because of a massive measles outbreak.
What triggered it?
Well, the background is complex, but your sources highlight a specific tragic event in 2018. 2 infants died after receiving the MMR vaccine, but it was due to the nurses mixing it incorrectly with something else. A human error, not the vaccine itself.
Okay, a preparation error.
Right. But anti-vaccination groups seized on that specific tragedy. They exploited it to spread fear and misinformation about the vaccine's safety across the island, creating deep mistrust.
And the result?
A devastating outbreak tore through the population, which had falling vaccination rates. The government had to take drastic steps, school closures, banning gatherings, eventually mandatory vaccination to get it under control, but not before many lives were lost, mostly young children.
It just shows the real-world harm of misinformation targeting vaccines.
Absolutely,
Yeah.
especially when it twists a genuine tragedy.
Let's shift gears a bit. How does this virus actually work inside the body? How does it take hold?
Okay, so transmission. It's mostly respiratory droplets. Coughing, sneezing, you breathe them in.
And it's airborne for a while.
Yeah, that's a key thing. The virus can remain infectious hanging in the air or sitting on surfaces for up to 2 hours after the infected person has left.
2 hours? Wow, okay, so you breathe it in, then what?
First, it sets up shop and starts replicating in the cells lining your trachea and bronchial tubes, your main airways.
And then it spreads from there.
Right. It gets picked up by immune cells, specifically pulmonary macrophages, which carry it into the local lymphatic tissues like lymph nodes. It multiplies rapidly there.
Okay.
Then, and this is important, before you even see the rash, the virus gets into the bloodstream. It travels hidden inside these infected immune cells, spreading silently throughout the body to various organs.
Sneaky. And the virus itself, what type is it?
It's a morbillivirus, technically a single-stranded, negative-sense enveloped RNA virus.
Okay. And it only infects humans.
That's correct. Humans are the only natural host. No animals carry it or act as a reservoir. It needs people to keep spreading. Which brings us back to how it spreads: coughing, sneezing, close contact, touching infected secretions.
One really critical effect of measles you mentioned earlier is how it messes with the immune system itself. Immunosuppression.
Yes, this is a huge part of why measles can be so serious. The infection causes a generalized weakening of the immune system. Your sources mention specific things, like decreases in certain types of immune responses and reduced production of key signaling molecules like IL-12.
And this isn't just while you're sick.
Now, that's the kicker. This immune suppression lasts for weeks, even months, after the acute measles illness is over.
Weeks to months. Wow, so that leaves you vulnerable.
Exactly. It significantly increases your risk of getting secondary infections, especially bacterial ones. This is why complications are so common.
Like what kind of complications?
Pneumonia is a big one, either viral pneumonia from the measles itself or more often secondary bacterial pneumonia. That's a major cause of measles-related deaths, especially in younger kids. Bacterial ear infections, otitis media, are also very frequent.
Are there even more severe possibilities linked to this?
In people with already severely compromised immune systems, yes. They can develop a progressive and often fatal type of pneumonia called giant cell pneumonia, caused directly by the measles virus running rampant.
But for most healthy people, the immune system does eventually win.
In immunocompetent individuals, yes. The immune system eventually mounts a strong response, clears the wild-type virus, and, as we said, you get that lifelong immunity.
Okay, let's walk through recognizing it. The timeline, incubation period.
From exposure to the first symptom is typically 10 to 12 days, but the range is about 7 to 21 days.
And contagiousness. When can someone spread it?
This is crucial for control. You can actually start spreading it 1 to 2 days before you show any symptoms, before the fever, cough, anything.
Spreading it before you even know you have it.
Right. Then, in a healthy person, you remain contagious until about 4 days after the rash first appears. For someone immunocompromised, though, they might shed the virus for much longer throughout their illness.
Okay, so those first symptoms, the prodrome, remind us.
High fever, feeling generally unwell, malaise, loss of appetite. And then the classic 3 Cs, cough, coryza, runny nose, and conjunctivitis, red, watery eyes. People might also get photophobia sensitivity to light, puffy eyelids, muscle aches.
And those spots inside the mouth, complex spots.
Yes, complex spots. Your sources call them pathognomonic, which basically means if you see them, it's almost certainly measles. They look like tiny bluish-gray specks, maybe like grains of salt, on a red base, usually inside the cheeks, opposite the second molars.
When do they appear?
They typically show up 2 to 4 days after the first prodromal symptoms start, and importantly, about 1 to 2 days before the main body rash. They only last 3 to 5 days, often disappearing a couple days after the rash begins.
Do you always see them?
Not always, clearly, no. So if you don't see them, it doesn't rule measles out. But if you do see them, it's a very strong sign.
Got it. Then comes the rash, the exanthem. What's that like?
It usually appears 1 or 2 days after the complex spots, so around day 14 after exposure, on average. It starts as flat red spots, macules, and maybe slightly raised bumps, papules.
Where does it start?
Typically starts on the face, upper neck, behind the ears. Then it spreads downwards, cephalocaudally is a term, down the trunk, arms, and legs over the next day or two.
Does it change appearance?
Yeah, as it spreads, the spots often merge together, forming larger patches or plaques. It tends to be most intense above the shoulders. Sometimes they can even look like tiny bruises, petechial.
And how long does the rash last?
Usually 5 to 7 days. As it fades, it often leaves behind a sort of brownish discoloration, coppery patches, and then the skin might peel slightly desquamation. But again, in severely immunocompromised people, the rash might be very faint or even absent altogether.
So putting it all together, an uncomplicated case runs its course in about.
From the late prodrome, when symptoms really kick in, through the rash resolving, usually about 7 to 10 days for the main illness. The cough, though, can linger for a bit longer sometimes.
Your sources mention variations too, like modified or atypical measles.
Right. Modified measles is just a milder version. It might happen if someone got immune globulin after being exposed. It gives some passive protection. Symptoms are less severe. Incubation might be longer.
And atypical.
Atypical measles is mostly historical now. It was seen in people who got the very early killed virus vaccine, used briefly back in 1963 and 1967. That vaccine didn't provide complete immunity. So if those people were later exposed to actual measles, they could have this weird, exaggerated reaction.
How is it different?
It often started with high fever, headache, muscle aches, then a rash that started differently on the hands and feet, spreading inwards. It could look varied, blisters, bruises, hives, often came with severe pneumonia. It was basically a hypersensitivity reaction in someone partially immune. The live, attenuated vaccine used since 1967 doesn't cause this.
Good to know. Okay, let's talk risk. Who is most likely to get infected if exposed?
Top of the list. Anyone with a weakened immune system, HIV, AIDS, leukemia, taking immunosuppressants, regardless of their vaccination status, they might not be fully protected.
Okay.
Also, travelers to or contacts of travelers from areas where measles is still endemic, circulating widely. And of course, infants who are too young for their first dose of vaccine, especially once the antibodies they got from their mother wear off.
And who's at risk for the severe form of measles, the bad complications?
Key risk factors for severe disease include malnutrition, any underlying immunodeficiency, being pregnant, and having a vitamin A deficiency.
Does age play a role in severity?
Yes, while anyone unvaccinated can get it, the highest risk for severe disease, needing hospitalization and developing complications, is seen in two groups: very young children, under 5 years old, and adults over 20.
What about sex or race?
In terms of just getting infected, unvaccinated males and females are equally susceptible. Interestingly, though, your sources note some observations of higher mortality rates among females after infection, particularly in adolescents and young adults globally. Race itself isn't a factor for susceptibility. Anyone can get it if not immune.
And the overall outlook, the prognosis.
Generally, for healthy people with good supportive care, the prognosis is good. Most recover fully, but it can be fatal. In the U.S., the estimated childhood mortality rate is low, maybe 0.1, 0.2%.
But globally, it's much higher.
Much higher. As we mentioned, that estimated 107,500 deaths worldwide in 2023. The mortality rate is significantly higher in children under 5.
Any specific groups with the highest death rates?
Yes, infants aged 4 to 12 months seem to have the highest rates, along with any immunocompromised children.
What are the main things that actually lead to death from measles?
Your sources list the most common causes of measles-associated death as pneumonia, severe croup blocking the airway, and encephalitis, that brain inflammation we talked about. Measles encephalitis occurs in about 1 in 1,000 cases and has around a 10% fatality rate itself.
Going back to complications, that immune suppression is the main driver, right?
Absolutely. It paves the way for either the measles virus itself to cause direct damage, or, more commonly, for secondary bacterial infections to take hold, or even for latent infections like TB to reactivate.
So pneumonia we covered. What else is common?
Otitis media, ear infections, are very common. Interstitial pneumonitis, inflammation in the lung tissue, croup, laryngotracheobronchitis, diarrhea, sinusitis, stomatitis, mouth sores. Also, transient loss of reaction to the TB skin test, and keratitis eye inflammation.
That eye inflammation sounds serious.
It is. It can lead to corneal scarring and blindness. Measles remains a leading cause of preventable blindness in many developing nations.
Any rarer complications listed?
Yeah, the sources list quite a few rarer but serious ones. Hemorrhagic measles, severe bleeding, purpura fulminans, another clotting bleeding disorder, hepatitis, liver inflammation, though mild hepatitis is common acutely, DIC, widespread blood clotting, thrombocytopenia, low platelets, even things like appendicitis, pericarditis, or myocarditis, heart inflammation, pancreatitis, low calcium levels, and that really nasty late one, SSPE.
Right, subacute sclerosing panencephalitis. Remind us about that one.
SSPE. It's a very rare but devastating degenerative brain disease. It happens years after the initial measles infection. The average is almost 11 years later. It seems the virus persists somehow in the brain, causing slow, progressive damage.
How does it present?
Usually starts subtly, with changes in behavior, personality, maybe a decline in school performance, then progresses to seizures, loss of motor control, severe neurological deterioration. It's almost always fatal.
And the acute encephalitis, different from SSPE.
Yes, acute encephalitis happens during the initial measles illness, about 1 in 1,000 cases. It's acute brain inflammation. As we said, fatal in about 10% of those cases, and many survivors have permanent brain damage. There's also an even rarer delayed acute form seen months later in kids with certain cancers, usually fatal.
And pregnancy, specific complications there.
Yes, for the pregnant person, there's a higher risk of measles, pneumonia, hepatitis. For the pregnancy itself, increased risk of premature labor, spontaneous abortion, preterm birth, though direct transmission to the baby around birth seems relatively low.
Okay, so given all this, if a doctor suspects measles, how do they confirm it for sure? Lab tests are needed.
Absolutely. Lab confirmation is essential, even if the clinical picture looks classic. It's crucial for public health tracking outbreaks, starting contact tracing immediately.
What are the main lab methods?
The primary ones listed are serologic testing, looking for specific antibodies, IgM and IgG, in the blood, and methods to detect the virus itself, like virus isolation, or, more commonly now, RT-PCR.
Which one gives the fastest result for a current infection?
Usually, testing for IgM antibodies is the quickest. IgM is the antibody your body makes first during an acute infection. You need to get the blood sample on or after the 3rd day the rash appears, as it takes a couple of days for IgM to be detectable.
How reliable is it?
It gets more reliable as time passes after the rash starts. Within 72 hours, maybe 77% positive, but by 4-11 days, it should be 100% positive if it's measles. though rarely other things can cause false positives.
What about the other antibody, IgG?
IgG comes up a bit later, usually detectable about 4 days after the rash, definitely by a week or so. For diagnosis, you typically need two samples, one early, acute, and one 10-14 days later, convalescent. If there's a fourfold or greater rise in IgG levels between the two samples tested together, that confirms recent infection.
But that takes longer.
Yeah, that takes about 3 weeks to get the final answer, which is too slow for effective public health control measures like isolating contacts quickly. IgG is also used to check for past immunity from infection or vaccination. Very high levels are seen in SSPE.
And detecting the virus directly, RT, TESH, PCR.
Right. Reverse transcription polymerase chain reaction. It's highly sensitive and can find the measles virus RNA, its genetic material in samples like blood, throat swabs, nasal swabs, or urine.
Is that faster?
Often, yes. It can provide rapid confirmation, sometimes even before antibodies are reliably detectable. The recommendation is usually to collect samples for PCR right when measles is first suspected.
Can you tell where the virus came from?
Yes. Another useful technique is viral genotyping. By sequencing part of the virus's RNA, labs can determine if the strain matches one known to be circulating locally, if any, or if it's likely an imported strain. This is really helpful for tracking outbreaks. PCR is also useful in immunocompromised patients who might not make antibodies well.
And reporting is key.
Imperative. Suspected measles cases must be reported immediately to the local or state health department. They coordinate the testing and response.
Is there a standard definition for reporting?
Yes, the CDC uses a clinical case definition for reporting purposes. Needs a generalized rash lasting 3 days or more, a fever of at least 101 Fahrenheit, 38.3 C, and at least one of the 3 Cs, cough, contagious, or conjunctivitis. Then based on lab results or links to confirmed cases, it gets classified as suspected, probable, or confirmed.
What if complications are suspected? Tests for those.
Sure. If bacterial pneumonia is a concern, a chest x-ray. If encephalitis symptoms appear, a lumbar puncture, a spinal tap to analyze the cerebrospinal fluid, CSF. The CSF usually shows increased protein, normal sugar, and a mild increase in white blood cells, mostly lymphocytes.
Any other tests mentioned?
Rarely, things like skin biopsies might show characteristic giant cells, or brain biopsies in severe encephalitis cases could show demyelination and inflammation, but these aren't routine.
Okay, so once it's confirmed, how do you treat measles?
The main approach is supportive care. There's no specific antiviral drug that's standard treatment for uncomplicated measles.
So what does supportive care involve?
Mostly managing symptoms, making sure the person stays hydrated, lots of fluids, IV fluids if they get severely dehydrated from fever or diarrhea, managing the fever with appropriate medication, rest. Hospitalization is usually only needed if complications develop.
Are antibiotics used?
Only if there's evidence of a secondary bacterial infection, like bacterial pneumonia or an ear infection. Antibiotics do nothing against the measles virus itself.
What about vitamin A? Your sources really emphasize that.
Yes, vitamin A supplementation is a key recommendation from the World Health Organization for all children diagnosed with acute measles, regardless of where they live. Specific doses are recommended based on age.
Why vitamin A?
Studies have shown it significantly reduces morbidity, the severity and number of complications and mortality by about 50%. It's particularly important for preventing severe eye complications and blindness associated with measles.
Any other treatments explored?
Your sources mention the antiviral drug ribavirin. It shows activity against the measles virus in lab studies, and it has been used experimentally in some very severe cases, especially in immunocompromised adults, or for that rare complication SSPE. But it's not FDA approved for routine measles treatment.
So treatment is mostly supportive, which really underscores the importance of prevention.
Absolutely. Prevention is everything with measles. Routine vaccination is the cornerstone. But there are also measures called post-exposure prophylaxis, things you can do after someone's been exposed if they're not immune.
Like the vaccine itself.
Yes, actually. The MMR vaccine, or MMRV, if given within 72 hours, so 3 days, of exposure, can actually prevent measles from developing, or at least make it much milder.
But some people can't get the live MMR vaccine, right?
Correct. Your sources list contraindications, people with severe immunodeficiencies, though. Importantly, this generally doesn't include people with HIV unless it's very advanced severe immunodeficiency. Also, people with certain cancers getting treatment, active untreated TB, those on high-dose immunosuppressive drugs, and pregnant individuals, they should wait until after delivery. And you have to delay it if someone recently received antibody-containing blood products.
So if someone in those groups gets exposed, what can be done?
That's where human immunoglobulin, or EEG comes in. It's basically a concentrated dose of antibodies. If given within 6 days of exposure, it can prevent measles or make it significantly less severe.
Who gets a yeek?
It's recommended for susceptible contacts who have contraindications to the vaccine, like the severely immunocompromised, pregnant women, or infants under 6 months whose mothers might not have passed on immunity. It's also used for infants between 6 and 12 months old who get exposed as a temporary measure before they're old enough for their first MMR dose. There are specific doses, sometimes given intramuscularly, IM, or intravenously, with high-V egg often preferred for higher-risk situations.
So post-exposure options exist, but the main goal is preventing exposure in the first place through.
Routine vaccination. It's the key. Following the recommended immunization schedule, like the U.S. 2025 schedule your sources refer to.
Are there specific recommendations for certain groups?
Yes, lots of specific guidance. For international travelers, based on age and vaccine history. For people with HIV, MMR is recommended unless they are severely immunosuppressed, and EG might be needed after exposure, depending on their status. Healthcare personnel need to ensure they are immune birth before 1957 isn't considered proof anymore. They need lab confirmation or vaccination. Special considerations for people on corticosteroids. The guidelines are quite detailed.
Okay, so summarizing the medications quickly. Vitamin A for treatment, ribavirin experimentally, MMR, MMRV vaccine for prevention and sometimes post-exposure, and immunoglobulin, IG, for post-exposure in specific cases.
That covers the main categories, yes.
Well, this has been quite the deep dive, really unpacking measles using these sources.
We've definitely covered a lot of ground, from its history and how common it was, to the impact of the vaccine, the biology of the virus, how it makes people sick, the risks, complications, and crucially, how it's diagnosed and prevented.
Yeah, the big takeaway seems to be it's incredibly contagious, can be really serious, but it's also highly preventable through vaccination. And this recent rise we're seeing is directly linked to gaps in that protection.
Absolutely. Which really leaves us with something for you, the listener, to think about. Given how quickly a disease like measles can exploit even small drops in community immunity, what does its resurgence tell us about that ongoing tension, that delicate balance between individual choices regarding health and vaccination and the collective health and safety of the entire community?
Hmm. It's definitely a complex issue and something worth mulling over as we navigate a world where these infectious diseases are, well, always going to be part of the picture.